Welcome to Conversations Live, Reimagining Healthcare. Tonight, as we meet, the healthcare systems in British Columbia and Alberta are grappling with several critical issues, including a shortage of doctors, frequent rural emergency room closures, and extended wait times. BC has a little over 15,000 licensed physicians, including specialists and family doctors, and Alberta has approximately 13,000. Despite this, access remains limited, especially in rural and underserved areas. Both provinces have invested in recruitment initiatives, yet a substantial portion of the population lacks consistent primary care, which unfortunately contributes to overcrowded emergency departments and delayed treatments. Now, that's just a snapshot of some of the issues that affect wait times, and if only healthcare was just about wait times, but it's far more complicated and disparate. There are no simple solutions, but it is clear we need to be innovative and we need to imagine a better future. Now, before we go any further, I'd like to acknowledge that we come to you from Malay, otherwise known as the place of many maple trees. These are the traditional territories of the Musqueam, Tsleil-Waututh, and Squamish First Nations who have lived on and continue to call these lands home. Osium. Conversations Live is a long-form public affairs dialogue series that seeks to advance our understanding of the big issues of our times. But we also strive to draw attention to organizations that make a difference in our province. Tonight, I want to introduce you to Owen McClung Sydenham. He is the co-founder and CEO of Helicopters Without Borders. Since 2021, HWB, or Helicopters Without Borders, has been delivering health and wellness services to remote and rural communities in British Columbia. Many of the communities have minimal or no road access. Helicopters Without Borders provides services to 3,000 people annually, services such as primary care, patient transport, disaster response, and food security programs. Over the past year, HWB conducted over 700 clinical sessions on traditional territories in BC. If you can, I encourage you to support Helicopters Without Borders. Please check out their website and contribute and help them to deliver these vital services throughout our province to underserved and very remote rural communities. So tonight, we're live from KPMG's Ignition Vancouver venue, in person and netcasting live on the Vancouver Sun, Calgary Herald, and Edmonton Journal. We're only able to bring these conversations live to you in person and live online thanks to the support of organizations that support engaged citizenship programming like this. You're going to see their logos all night long as they scroll across the bottom of the screen. And I'm going to tell you that I can't thank them enough, and I'm going to name them all right now because without them, we just can't do this. Our hosting sponsors are KPMG, RBC, and Macmillan LLP. Our annual sponsors are BD Developments, Stem Cell Technologies, Rennie & Co., LNG Canada, Landlord BC, Pacific Salmon Foundation, TC Energy, Fortis BC, Polygon, Digital, Helijet, and TELUS. What a remarkable group of companies, and I thank you so much for your support. And our supporters are also BCIT, OPI, and West Coast Reduction. And we work in association with Apogee Public Relations and Research Co. As I say, without their generous support, this program would not be possible. Now, one last little bit of business before we get going. For anyone wishing to submit a question, whether it be from our in-person audience or online, please go to slido.com, enter the code Conversations Live, and send in your question. And Sean over here is our Slido master. He'll be receiving your questions and he'll share them with the panelists. Now, just before I introduce you to our panel, here is our poll from Mario Canseco of Research Co. Arav, can you roll Mario's clip?
There are some fundamental differences in the way residents of British Columbia and Alberta ponder the current state of healthcare. Most BC residents think there are some good things in the system, but many changes are required, a view shared by almost half of Albertans. Fewer than 1 in 4 residents of each province feel the system works well and only minor changes are needed to make it work better. However, while 1 in 4 Albertans say the system has so much wrong with it that it needs to be completely rebuilt, fewer than 1 in 5 BC residents feel the same way. At least 1 in 5 Albertans identify long wait times and bureaucracy and poor management as the biggest problems facing the healthcare system right now. The notion of inadequate resources and facilities resonates with about 1 in 10 residents of each of the 2 provinces. Still, the most significant challenge identified by residents is a shortage of doctors and nurses, amounting to more than a third of responses in Alberta and more than 2 in 5 responses in British Columbia. At least a third of residents of both BC and Alberta express little or no confidence in the healthcare system being there for them in a time of need. The perceptions are slightly higher among those aged 55 and over than among each province's youngest residents. British Columbians and Albertans who have received healthcare virtually are satisfied with their experience. Fewer than 1 in 5 residents of each province are unhappy with the quality of care they received through video, phone call, or email. It is important to note that the level of satisfaction with virtual care is slightly higher among residents aged 55 and over, traditionally the demographic that is most reliant on the healthcare system. The notion of healthcare delivery being superior if it were run by the private sector resonates with about 1 in 4 Albertans and about a third of British Columbians. In Alberta, more than half of residents disagree with this notion, along with almost half of BC residents. For Conversations Live, I'm Mario Canseco from ResearchGo.
Thank you, Mario. I think, the numbers suggest there is a significant appetite for improvement in the delivery of healthcare in BC. It's improvement. It's not just sitting there saying this isn't working, that isn't working. It's what can we do to make our system better. Our panel tonight and video contributors bring together representatives from BC, Alberta, and interestingly enough, Nova Scotia. We've got a clip from there. And our in-person panelists are Mary Ockenhusen, the past CEO of Vancouver Coastal Health, Valerie Lukac, the partner at KPMG's Health Advisory, Dr. Anna Kindy, who is on screen. She joins us live from Victoria. She is now the Conservative Party critic. Suzanne Gill, the president and CEO of Genome BC. Sue Paish, the CEO of Digital, and Dr. Brian Day, the founder and lead at the Canby Care Center. Mary, I really want to start with you. We saw in Mario's poll that there is an appetite for change. And we've been seeing this appetite for change for a long time. Why, with so many people wanting change, is it taking so long, or is that change so elusive?
Oh, wow. It is elusive. And I'll start with the positive, which you saw on the poll, which is that people are more and more ready for change. We see that through Mario's poll, as well as other polls that have come out. Navigator poll, and for example, in the Globe and Mail was published, said many of the similar things. And yet our politicians, our leaders, aren't able to manage that change. And why is that? And that's something that I spent my career thinking about, as I've always been very passionate about transforming the healthcare system, and as an industrial engineer by background, realized that the processes we use, the system approach, it's very incremental, and we're not giving citizens what they need and what they deserve. So I studied innovation before I went into healthcare, and when I left Vancouver Coastal Health, I was at the ministry for a while, and I studied innovation at that point. And I spent time thinking about this in terms of why is it that some large, complex, and even monopolistic organizations can change, can embrace change and transformation and innovation on a long-term basis, decade after decade, and some others, like the BC healthcare, Canadian healthcare system, are destined to incremental change, and that's kind of the best they can do. And there are about 9 characteristics that you can identify that you'll see in complex, large organizations that are able to change on an ongoing basis. And when you compare what healthcare is, how they achieve on those characteristics, they don't do well, let's say it that way. So let me just talk about two, because I think two will give you an example of what I'm thinking about and basically what you would live if you were in the healthcare system today, working in it. One of the first things that's very important for large, complex organizations that are able to change continually is that they give equal value to innovation, R&D, as well as operations. So yes, as a consumer of the healthcare system, operations are critically important. You need to know that that healthcare nurse is going to be at your home when you expect them, and she'll have or he'll have the right equipment, et cetera. So that's kind of operations, getting the trains to run on time. But equally important is that concept that there is a future, and we have to continue rethink and modernize and basically reinvent ourselves as the demographics change, as disease cases change, as technology changes. How are we reinventing ourselves? How do we emphasize that? And I think that's where healthcare comes up pretty poorly. We don't spend a lot of time, resources, we don't reward people particularly well for that. So status quo, incremental change becomes the norm, and that's darn good. You can get promoted and you can get, all you need in a healthcare system from that. And basically that's what the ministry and governments generally ask for. So when going back to if our citizens are asking for more change, hopefully that helps politicians to take more risks and to drive a different type of leadership through the healthcare system. And another quick example is focus. So in healthcare, if you look at what management teams are asked to do, every year they get a list of all the things to do, mandate letters, and there are multiple, 40 different things to be done and to be measured and to be achieved. But of course, if you have 40 different foci, you have no focus whatsoever, and your resources are scattered, and incremental change is probably the best you can do. But there is hope, and I will close with this because I know this is a little bit of a long answer, but it's so important to me in that you can have tons of innovations, but if you can't implement them, if you can't implement change, they're for naught. But we have shown in the healthcare system that we can spin on a dime, and we did that through the pandemic. And we had all those elements that I'm talking about in terms of we had a focus. We knew exactly what had to happen. We knew that our role as healthcare providers was, one, make sure the hospitals don't get overloaded. We don't want to be overwhelmed. And secondly, make sure people don't die. So everything else came off the table. That was the focus. All the other meetings, all the other things we were doing, stepped to the side, and we created mean decision-making teams that could be fast, nimble, brought in innovation from the outside, from private sources. We tried lots of innovations. The ones that worked, we kept. The ones that didn't work, we put to the side very quickly and tried something else. So we were an example of what is actually possible, even with a very complex, large, bureaucratic, monopolistic healthcare system. So it has not been retained. Many of us afterwards hope that this is a new era and that we will continue these types of behaviors, but that has not been the case. But we do know it's possible.
Well, in an interview that I did with Dr. Sylvain Morneau, he at the time said we were leading the world in the way that we were addressing so many of the challenges that COVID presented through our online telehealth outreach programs and so on. And then we stopped. And Sue, you know this so well. I mean, look at the work that you're doing at Digital. You're supporting innovation, made in BC innovation. Tell us from your experience, like what are some of the things that British Columbia companies are producing, but where's the technology going?
Yeah, well, I'm going to thank you, and I'm going to pull on the string dangled by Mary in terms of being optimistic. I'd say perhaps a little bit frustratingly optimistic, but optimistic nevertheless. And let me just frame it a little bit, just a few data points to add to what's already been said, in case we wonder whether or not there's an issue here or an imperative. Healthcare systems are the single largest budget item in every provincial budget in the country. It is growing faster by multiples of the GDP. And at the same time, I think we know across the country, we are an aging population. And as we age, present company excluded, as we age, we are bigger users of the healthcare system. The math does not work. We can't continue to have healthcare costs rising faster than our GDP and hope that we can continue to do other things like education or business growth or natural resource exploration or any of those other services. So it is time to really get serious about this. And at Digital, when we were created in 2018 with the mandate of digital, it's kind of a broad mandate, and we thought, well, focus is really important. What's one of the most important things for us to address in terms of an innovation organization? It's the healthcare system. And here's the good news. I could stay here for the rest of the evening and lock the doors and regale you with all of the technologies that have come out of our model, but I'm just going to tell you a couple of stories here. And before that, tell you about the model. So the model's really unusual. The model says, let's put people around a problem that would not normally be at a table together and might not even want to be at a table together to solve some of industry's and society's biggest challenges. So let's take, for example, the example of wound care. You might not wake up in the morning every day thinking about wound care, but I can tell you, during COVID, wound care was right at the top of the list. Why? Wound care is about 30 to 50% of healthcare costs. It's surgical wounds, it's bed sores, it's all kinds of issues like that are cared for pre-2020 with somebody coming to the bedside, either in a facility, in a hospital, in a long-term care facility, or a community care nurse at home. That all stopped, dead stop, when we got into the COVID dynamic. And so how could we solve this? You put academics at the table, you put large multinationals at the table, you put small innovative companies at the table, you put physicians at the table, you put healthcare leaders at the table and say, what do you got? And what you come out with is a technology called telewound, which is in effect an app, for about lack of a better word, that you can put on your phone and take a 3D medical grade image of a wound that is transmitted with the help of AI, interpreted, transmitted to wound care specialists who can inform the patient or the caregiver at the bedside on what to do with that wound to help it heal faster. And that technology is deployed in lots of places around the world, not fully deployed in British Columbia, but it is deployed in lots of places around the world. And we're seeing a dramatic increase in the costs of wound care, a dramatic, decrease in the cost of wound care, a dramatic, decrease in the cost of wound care, an improvement in healing of 35%, and a reduction in readmissions of 50%. So 50% fewer people are showing up in a hospital or a doctor's office with complications from a wound through this technology as compared to when we didn't have the technology. So that's one example. Another example, let's think of ultrasound. So just think of ultrasound for a minute. It's a huge piece of infrastructure. If you've had an ultrasound, you know that it's a fairly significant piece of infrastructure that you have to travel to if you are in a remote community and you need an ultrasound. We couldn't do that during COVID either because we couldn't travel to the healthcare systems and healthcare facilities, and yet we still needed ultrasounds. So a little Vancouver-based company creates an ultrasound basically in your hand. Think of a little bit bigger than your cell phone. And here's how it works. You're kayaking off, let's say, off Haida Gwaii, and you're an athlete, and you're kayaking, you don't feel well. So you keep kayaking, right? Because it's going to make you feel better. But you feel worse, and you realize something's not right. So you kayak into shore, you walk to your doctor's office because you can, and the doctor does a few quick tests and thinks something is wrong. Whips out his handheld ultrasound, does the ultrasound scan, which transmits the data to the cardiac care unit at St. Paul's Hospital, who immediately look at it with the help of AI, get back in touch with the doctor up in Haida Gwaii and say, get this patient in a medevac. She's not well at all. And your life is saved. Or at the opposite end of the province, you're a tourist from the United States, you're pregnant, and you go into early labor on Salt Spring Island. The midwife takes a look and says, this doesn't look right, just the way the patient was reacting, pulls out her handheld ultrasound, scans the mom, transmitted to the neonatal unit. They guide the birth to a healthy delivery, which the midwife says was likely not going to happen. This is the kind of technology that is literally in our hands, and it's deployed in jurisdictions from the United States to Brazil to Mexico to England, and maybe one hospital or one health authority in Ontario. And so the opportunity is right here. And as I say, I could regale you for a long time with other examples of very pragmatic technologies that can reduce costs, improve access, improve outcomes, and they're made in Canada. And they're developed by Canadian companies. And so the block that we've experienced is inertia. A little bit, and I'm going to pull a little bit on some stuff that Mary you didn't say this, but I'm going to take a little bit of liberty with what you said, a fear of making a mistake. And we would rather not make a mistake in the healthcare system than do something that is really transformative. And a lack of any sense of urgency in terms of the need to move with speed to change the way we do things. That said, I remain forever optimistic that we will find a way, whether it's another pandemic or not, to get some of these technologies deployed.
So I'm hopeful that you're saying when you give the Haida Gwaii example, at least it's available in Haida Gwaii.
That particular technology is serving about 70,000 British Columbians. Okay, there's a few more that could benefit from it. So it's being deployed one facility at a time for 4 million people. We can do better.
Wow.
So about 70,000 British Columbians have access to that, and they are in the, I will say the good news is they are in people who are in remote, rural, Indigenous communities who have very limited access. But I think the health systems in the urban areas would benefit from having more accessibility to their in-house ultrasound if the rest of the physicians had access to it.
Dr. Kindi, you joining us from Victoria, but you have also recently taken on the role of health critic. But you have spent your life, and so has your family, within the system. What you've heard so far tonight, how does that inform you in the way in which you want to be able to work with the government to improve our willingness to accept innovation?
Well, I think, I'll go back to your question, why are people ready for change? And so, when I hear optimism, I think, if you're the person waiting for surgery and you've got cancer, I don't think it's a time to be optimistic. It's time to realize that we have a true healthcare crisis. I come from a rural setting, and when we talk about innovation, I totally agree that we need innovation, but we have to look at the facts on the ground. And the facts on the ground right now is, as a country, we're on the top tier of what's called OECD countries. These are countries with universal healthcare in terms of how much we spend per GDP. And we're at the bottom or close to the bottom of the list for, number of doctors, number of nurses, and number of hospital beds. So when we talk, and I'll go back to the, we were talking about wound care for a little bit there. So my husband's a plastic surgeon, and, so he deals with wound. And unfortunately, when we're in a position, when, policies say that we should have 4-to-1 nursing ratio, often nurses are working at, 7, 8-to-1 ratios. So, it's difficult to think of somebody who's paraplegic and you need to move them and you don't have the time for it. So often, sometimes wounds get worse in a hospital setting because we don't have the people on the ground. I think, having come in from a system where, 25 years ago as a physician, people, we were, as healthcare workers, we were optimistic. We could get our patients in. And now I'm not hearing optimism on the ground. People are, they're burnt out and a lot of people are quitting. Second is, when we're talking about sort of innovation that and I think I mentioned that previously when we talked before meeting here, we have, for example, a lab in Campbell River, and we went from 14 tech to 3 tech, and we were going to close our hospital down because we couldn't even take and give blood in a hospital setting. So we're looking at a crisis. And we're spending a lot of money. and the bureaucracy seems to be ballooning. And so, you almost have to look at the system and not sort of patchwork it. You have to kind of look at what other countries are doing, which seems to be working much better than we are. And I think part of the reason I think bureaucracy is in moving quickly is, number one, it's too big, and number two, there's no accountability. We need to look at the data. We need to see what's working and what's not working, and we need to do it quickly. Because people in Canada and BC, I mean, we deserve better for healthcare for the amount we're spending.
Valerie, I'm going to come to you in a second, but Arav, can you just play the clip from Leanne Hackey from Nova Scotia, where they have gone full on to take on exactly what you were talking about, Dr. Kindy, the bureaucracy?
Red tape is very vague. You know it when you see it, but it's hard to articulate what exactly it is. I think one of the reasons that we've made the advancements that we've had is that we put numbers to it. This is not just about one or two useless forms. This is about tens of thousands, hundreds of thousands of hours of physician time. And I think that's really been the difference maker, being able to put a number to it so that people can really see the impact. Because as I said, when we first started this, departmental partners, who again are awesome, but initially they said, give me a break. We only ask our physicians to complete 5 forms. Well, you ask the physician to complete 5 forms. The department 3 doors down from you asks for 10. Our workers' compensation system asks for 30. These things all of a sudden add up very quickly. And we asked them how much time they spend on administrative work and how much of that time would they consider unnecessary. They considered about 35% of the time that they spend on administrative work as unnecessary. That's the equivalent of about a little more than 500,000 hours per year on unnecessary work. Well, that's a lot of time. I know that's the equivalent of 1.5 million annual patient visits. So then we asked them, okay, well, what are the categories that you would consider unnecessary work? And there's 2. One is work that physicians were doing that another healthcare professional has been trained and licensed to do but isn't doing. And then the second bucket was work that no one should be doing. So in the first bucket, we have done in Nova Scotia, again, with our many government departmental partners, is do things like expand the scope of nurse practitioners, enable physiotherapists to send someone for an x-ray, hire physician assistants so physicians aren't doing that initial medical exam, allow nurses to onboard new patients so that doctors don't have to spend hours and hours completing a new medical record for a patient. That's work that all of those folks have been trained and licensed to do now, that takes that work off of physicians so they can do work only they can do. So that's one bucket. And the second bucket is work that no one should be doing. And that is really about looking at the kind of forms and processes that we have asked doctors to complete and ask ourselves the tough question, do they really need to do this? Do we really need to ask doctors to fill out a 15-page form to enable someone to access employment supports if they are having accessibility issues? Do we really need to have 15 different forms for the insurance industry or 26 different forms? Do we really need for that to be the case? Do we really need to ask physicians to complete sick notes for someone who is not feeling that well? They don't need to go to a doctor. We should be trusting the employee's judgment that they're not well and let the employer and the employee figure that out rather than wasting a doctor's time writing a sick note. So with all of this work, we are about to meet our target of lifting about 400,000 hours annually from physicians by getting rid of this unnecessary work or enabling those healthcare professionals to work to their full scope of practice.
Rather amazing, isn't it? Yeah. She pointed out that it comes with the authority that came from the Premier who said, we're doing this. And so, Valerie, systems and your international experience, when you have listened to what we've discussed so far, where do you say, okay, there already are lessons here and opportunities for us to start to innovate in ways that can save time and deliver greater healthcare practices or services directly to patients? Because that's the goal.
Definitely, that's the goal, and increasing access to care at the forefront as well. So pulling on some of the comments you made, Sue and Mary, as well, is thinking through decision making. And I think the current system is not only scared of making a mistake, but scared of making decisions that are significant enough to make an impact, to change the course of patient care. And a lot of what they're doing in Nova Scotia is redesigning the healthcare system, thinking through the administrative burden, but also thinking through who is caring for the patient and who at the forefront is enabling that patient to get the care they need early on in the system. I think our healthcare system is very well suited to you being very sick. If you need a heart transplant or if you need open heart surgery, you're going to be cared for very well and you'll be discharged and you'll go home feeling much better. But if you have a need for a primary care physician, you could wait for weeks. And if you have early stage cancer, you could wait for years to be diagnosed, and then it's too late. You're already stage 3, stage 4, and it's too late in your journey to actually be cared for efficiently. And so we care for the sick, but not really for prevention and for the public health at the core. So making difficult decisions is going to be key to actually enabling the primary care and keeping the population healthy, which is challenging. It's an election cycle, right? So every 4 years, politicians need to be re-elected into a decision-making process, and it takes more than 4 years to make a huge impact on changing the healthcare system.
Brian, you have long been pointing the finger at this very issue. There's so many layers of bureaucracy and systems that stand in the way of efficiency, to the point where you're saying, well, allow us to help out, and yet the response that you get is no thanks.
Yeah, you know, I don't think it's that complicated. You know, it's like there are a couple of athletes in the front row on my left here. I don't think they'd want to be named, but maybe they would. But to me, using the sports analogy, the Commonwealth Fund and OECD, we're ranked near the bottom. We're in terms of performance in by all the criteria that you can look at, whether it's access to care, access to technology, access to doctors and nurses. And if you were the manager of a sports team, you were coming bottom you're in the last group out of the whole league, and yet you were spending more than anyone else in the league. Wouldn't you think, well, I think I'll look at what the top 2 or 3 teams are doing and learn from their coaches and learn from their methods, and that's what we need to do. This is not rocket science. This is learning from the best performers. And you know, I think not enough. As you know, I don't support. By the way, in that poll, I would have said no to the private sector running healthcare as well. So I don't think the private sector should run healthcare, but I think it has a role to play, as it does in every other country, in terms of allowing an option to the government monopoly that we have. So not enough. Oh, am I cut off? Oh, I thought
you were just grabbing the transmitter.
Oh, so I'm sure there are people there out there who'd want to cut me off.
Maybe.
But I mean, this is to me, we are underperforming for the price that the taxpayers are paying for this health system. That the public are ready for change, and I think yes, all of the things that the panel have talked about are important, but let's face it, there's a massive shortage of doctors. When I came to Vancouver over 50 years ago, we were between 2nd and 3rd in the world in doctors per population, thanks to government policies. And this was the NDP government of the 90s. We're now ranked 69th in the world in doctors per population.
I think you mean the 70s.
Yeah, I came in the 70s. So now,
okay.
We're now ranked 69th in the world.
Right.
We used to be ranked between 2nd and 4th.
In the 90s?
In the 70s.
Oh, okay, in the 70s, yeah.
In the 70s.
Yeah.
So we've just been getting worse every year. And the solution, and the same with nurses, a lot, you know, the government in the 90s decided that the rising costs were caused by nurses and doctors treating too many patients and causing massive costs in healthcare. So they closed medical schools and cut back medical schools by up to 30%, and closed nursing schools. You know, the VGH and the St. Paul's had big nursing schools. They were all closed. And guess what? We have a shortage of nurses and doctors, thanks to the government. And now the government's saying, well, you know, we need more doctors and nurses. Well, you know, the point is that if you look at other countries that outperform us, we can go into details on what they're doing and what we're not doing. But not many Canadians know we're the only country on the planet where it's illegal to get private health insurance for even when you're suffering from a serious illness. And then, as others have alluded to, the politicization with the electoral cycles of 3 to 4 years means there is no long-term planning. Like no government of today is interested in making a government 15 years from now look good by planning ahead. They just plan for the next election. So having a state monopoly is not good for patients, and it's not good for the public, it's not good for the health system.
So I take a look to Ontario right at the moment, which is basically saying you want to come here and learn to be a doctor. We're going to give preference to Ontario-born students who make a commitment to stay. What's your response to that, or reaction to that policy?
Well, I don't blame them, but the fact is we don't have enough medical schools, and we need to build more medical schools, and we need to open up nursing schools again, and and we need to make it. I mean, you know, I'm an immigrant doctor. We need qualified people from out of the country. We need to bring them in, but the problem is the funding system. The other unique thing about Canada, which I've mentioned many times before, in the OECD, we're the only country that pretty well exclusively block funds hospitals, so that every patient going to a hospital is using up their annual revenue. Whereas in the British NHS and in Germany and Switzerland and Holland and New Zealand, Australia, when a patient goes to a hospital, even in the public system, they bring revenue. The government, if it's in the public system, the government brings revenue to the hospital. So everyone is geared to looking after and wanting patients, whereas a well-performing hospital that gets new technology and embraces the latest and greatest and attracts patients is going to suffer because their budget will be used up quickly.
So I'm going to make reference to one of the athletes in the room that you were talking about, Dr. Doug Clement, because in a conversation that I had with Doug Clement, he said, you know, we are in a unique position here in British Columbia. We're so far ahead in advancing the study of genomics. There's so much that we can do. And on the preventative side and where we're going to be able to go and with specialized treatment, we can get there. But bringing it all into the system is still challenging. Suzanne, genomics, what role can genomics play in helping to alleviate pressure on the system, both in addressing current healthcare situations, but also with a long-term view in moving towards personalized healthcare?
No, thank you, Stu. Genomics is underpinning the future of healthcare. There's no question about it. And actually, 21 years ago, actually, we celebrated the completion of the first reference genome for a human. Mm-hmm. And so we've been living with that information and all the research that has come after that. We've had this information for 20 years, built upon it. We were at the cusp of transformative change for medicine and how it's delivered to patients. And there's no question we do lead in this country, in Canada, and in BC. And So yes, I would echo the system needs to be ready. The healthcare system needs to be agile enough and have a way of making decisions when it comes to new technologies, new innovations, the implementation of clinical genomics to treat patients in a way that is not so slow and rigorous where it is right now. So that means and I'm not a systems person, but there's a whole lot of things need to change, from policy to regulations to actually how it gets implemented into the system, how health authorities or hospitals are funded and rewarded to being innovative. And just on the genomics piece, I mean, in BC, we're fortunate to have a Michael Smith Genome Sciences Center, and I know you had Dr. Mark O'Mara and part of his team here. And with that asset, it's incredible. It's built within a health authority within the BC Cancer Agency. And with that, we had some world's first here in BC. We had Dr. Sam Aparicio and his team, as you heard a couple of days ago and was on your program, sequenced the first solid breast cancer tumor in 2009. Then came the Personalized Oncogenomics program, which also used the Michael Smith Genome Sciences Center, as well as other researchers, to do a world's first and sequence the first human and their cancer. And that happened here in BC. Now, imagine what should happen. That shouldn't be research. We've been, 20 years from now, maybe 5 or 10 years, if I had my say, that would be mainstream, that you would walk into a clinic, you would have your genome sequenced, your cancer sequence, and you'd know what path to follow for precision healthcare, what drugs to take, what you need to do to treat your cancer or what other issue. That's the vision of the future, but we fund a lot of research in world-class research, but it needs to go somewhere. It needs to be adopted. It needs the partners at the other end to have the right systems in place to really enact change. And that's the clinical interface of research. And I think that's very challenging right now, which is why also research groups work, like Genome BC, work with others. How do we educate the healthcare practitioners, the nurse practitioners, in understanding what it means to understand a genomic report? How do we embed clinical counselors and genetics in physicians' offices in rural communities? Anyway, I could go on. There's lots.
Well, that's exactly Dr. Doug Clement's point as well. It's got to start at the medical school. They have to have an understanding that if I go and get my genome sequenced and I show up at the doctor's office and say here, the doctor has to know what to be able to do with that. And that's a part of it. Sue, I see you wanting to jump in. Oh, and Brian, I'll come to you right afterwards.
Yeah. Just pulling on the thread here in a positive way as well. We had Michael Smith, we had Don Ricks, another leader in genomics, and to be positive, we do have platforms that again have been developed through, and you've been part of it. You were with us when we were doing this. We've got platforms that are using genomics. Now, this is not BC-based companies, Ontario-based companies, but using genomics to help identify new combinations of medications, new ways of treating autism, and using the genomics to identify, well, the treatment that you're using for this autistic patient is not going to work because their version of autism is actually different based on the genomic data that they have. And so we have the opportunity, we have the technology. Technology is not the block. Science isn't the block. It's mindset. And to echo what was said earlier, maybe some of the political mandate or the political inspiration. But somehow if we can unlock the opportunity to actually deploy these technologies and marry up private sector with what Genome BC and Genome Canada do and the other genome centers, there's a whole world of personalized medicine that is literally on our doorstep.
Brian, I saw that you wanted to comment,
Well,
and then Anna, I'll come to you right after.
Well, it's just, in the same theme, one of your sponsors, Stem Cell Technology, I know Alan Eves is keen to expand that into clinical use, and yet, the problem again is that in our system, anything that's, I've received, this was before Mary's era, I've received letters from administration at the hospital when I wanted to bring in new technology that was better for patients, saying, well, the problem with that is that it's going to attract too many people, and we can't afford to have all these people coming to the hospital for this new technology. But I know Alan Eves of stem cell technologies is keen to expand its clinical use in British Columbia, and we need new technology. We should be at the forefront of new technology, but there are until we get over the basic problem in that our system operates on 3 to 4 year financial cycles, and even the CEO of a big hospital like VGH and St. Paul's, they really don't have any power because they've got to do what the tiers above them tell them to do. So the buck stops at the highest level of provincial and federal governments, and it is this politicization of our health system is ruining the health system.
We have Wendy Herbert from the Life Sciences Association with us in the audience, and of course, she and all of her members are anxious to be able to bring innovation to address these same challenges. Anna, you...
Totally agree. But again, it comes down to the dollars, right? So at this point, we're universal healthcare, publicly funded. That's it, and we're spending so much. So where does the money go? And can we, at this point, access innovation? Well, yes, if it saves money, but that means you need to cut somewhere else. And this is where, I think two things is people. I'm from British Columbia and I'm elected in British Columbia, but people in British Columbia deserve to know the truth, right? So what we need to do is have data accessible to people on the ground so that, they know what we're working with. I think, to access data is very difficult, and who's collecting the data? And are we actually, our huge bureaucracy, are they accountable to that data? So I think we need to, focus again on, changing the system so that we can afford to bring in the innovation. And, and the way to do that is become more efficient and also look at alternatives. And like Dr. Day said, sometimes you don't need to reinvent the wheel, and it's not rocket science. Some countries are doing better than we are. And why is that? And I think we need to also, be, honest with the people, as a politician, honest with the people in British Columbia. People don't want to hear sort of more, I don't want to use the word propaganda, but, for so many years we were hearing that we had the best system in the world. And we, my husband and I were working in it. And 25 years ago, yes, I probably would say that we had one of the best systems. But in the last 10 years, especially in the last 5 years, no, we don't. We're at the bottom of the list. And we need to repeat that. And sometimes you don't even need to repeat it because people trying to navigate it through it see it. And that's why there's appetite for change. And I think that appetite for change will enable actually politicians to make longer term plans. That's my thought. Again, because when you're in a crisis, people want that change. So in that way, I am optimistic that I think we're at the cusp and things will change.
Sean, I was planning on coming to you, but I saw that Valerie and Mary want to make a quick comment. Then I'll come to you from a comment from a viewer. Valerie? Yeah.
Just going back to the administrative burden, I think that's where innovation and technology will start to play a bigger role. We're seeing the adoption of AI, and everyone will have to move on with adoption of AI, whether they're scared of it or not. It's coming for you. And so you might as well use it and start to adopt it. And it actually can be a very powerful tool to reduce the administrative burden. Filling out these forms that you have triplicates and 30 different forms to fill out, it can do it for you. It can summarize information, it can summarize multidisciplinary clinical meetings, it can really help in creating more of a balance between the demand that we have too much of and the lack of supply of clinicians and administrative practitioners in healthcare.
Mary?
Somewhat similar, maybe give a few more examples, because I really appreciate what Anna's saying, and she's really bringing up the dilemma of a healthcare administrator or a bureaucrat within the Ministry of Health is, I don't have enough money to even do what I'm doing now and do it well. So where do I find money to invest in, new technologies, to invest in genome testing for, at least for proven cases for various disease states? How do I do that? How do I balance it? And I think the answer there is exactly what Valerie was alluding to, is there's some change that needs to happen that's killing us right now. And probably the biggest thing, which has been touched on, but is what every healthcare administrator thinks about every day, and that is the shortages. You're working short in the emergency room, you're working short in the home care, you're working short in the hospital, and it's a circular problem that just gets worse because burnout, and people are only going to stand for that so long before they decide healthcare is not for me, I'm going to go to do something else, which we have seen primarily with the kind of middle-aged cohort post-COVID. It wasn't the older people with the pensions that are invested that left and didn't come back. It was the kind of well-trained mid-career folks. So, if you start with, okay, how am I going to solve these problems where I don't have enough home care nurses? 15-20% vacancy rate in home care nurses. We know that we're supposed to be caring for more people in the community, less in the hospitals, but I can't do it because I don't have nurses. Well, there's a lot of inefficiencies, even before you come to AI, that can be used to improve the number of patients that can be seen, and making sure you're seeing the right patients in the community. There's some new technology that's very well tried and true in other countries. The telewound that Sue brought up is a great one to improve the productivity of home care nurses dramatically, like 20-25% potentially, those kind of things. But it all comes down to, we're not good at introducing change in a big way and with any sense of urgency into the healthcare system. So until you have a courageous, ambitious approach to solve that problem, it doesn't matter whether it was lean healthcare 15 years ago or AI, which is facing us right now, the system will resist. The system will say it's not safe. The system will be very incremental in introducing it. And that's not what we can less and less afford that for all the reasons that the other panelists have said. So this is our opportunity to really push forward and find that leadership, hopefully to make the changes necessary in terms of how we accept change, accept these new ideas that are so powerful and so badly needed.
So one of the things that I note in both British Columbia and Alberta, if you bring up this change, there is resistance not just within the system, but within the public. Sean, you have a question from a viewer, I think that helps to demonstrate this point.
A question from Tuesday Andrich. The data proves that the existence of a private and public healthcare sector siphons workers away from the public sector, leaving understaffing publicly. Wouldn't it be better to focus on strengthening the public system and not breaking it?
Brian, I know you're going to jump in on that, right?
But that data doesn't show that. You see, this is the trouble. If you say something often enough, people start to believe it. And the data from the top performing countries in the world are countries like Germany and Holland and France and so on. Germany, these countries don't have the problems we have. We're spending a lot and getting little. I had a fellow visiting me from Germany, an orthopedic surgeon from Bonn, and he, I kind of knew the answer to the question. I said to him, because in Germany, 90% of the system is public, 10% is private. And in Switzerland, where I worked, it's almost all private. But if you're a low income, the government pays the premium. So that you don't necessarily need the state to ensure universal health care. And so this German orthopedic surgeon, who's a young orthopedic surgeon, I said to him, how long would you wait for a hip or knee replacement in the public system in Germany? He says, a long time. I said, well, compared to the private? He says, yes. I said, how long would you wait in the public system? You could wait 5 or 6 weeks. And and it's only a week or two in the private. So yes, it's not equal, but that shows you what, to me, what competition, and these countries at the top of the list in terms of performance, they're all performing in that range, and we're not. We're way down there. So having a state monopoly does not. And the reason why there's a shortage of doctors and nurses is it was government policy that we will. The doctors and nurses. This was a diagnosis of the Seton Commission in 1991 that too many doctors, too many nurses, treating too many patients. Let's cut back on medical schools and cut back on nursing schools, and that will save the system. And that's where we are today.
Mary, and Anna, I'll come to you right after.
Having worked in the public sector in healthcare, my whole career was in the public sector. I have a great appreciation still, though, for the private sector, because the private sector sets a benchmark that the public sector should try to achieve. If you look at the comparison between surgical satisfaction as well as outcomes in private centers versus public centers, certainly the satisfaction is most usually uniformly higher in private sector, though fortunately the outcomes are pretty good in both. But I think the whole idea is that the private sector is there and can keep the public sector on its toes and make it become more ambitious. And one of the ways the private sector does sometimes attract more people from the public sector in a negative way is because the working environment is just better. So one of the things that was a great concern to me when I was at Vancouver Coastal Health was basically, do you like to come to work? Are you able to do your best work when you come to Vancouver for your job? Are we a supportive employer in that way? And unfortunately, the answer wasn't one I really wanted to hear. It was kind of no. And I don't think Vancouver was any different than any other health organization, probably throughout Canada. But there's a reason that we have unions, and there's a reason the private sector maybe doesn't have unions for the most part. We need to respect our workforce. If we don't have a workforce that can do their best job every day, we are a service industry in healthcare, so you can imagine that that's not really a good formula. So I never want to forget about the staff and the doctors. What do they need to do a good job? And then I think there is a balance between private and public.
Anna and then Sue, okay?
Yes, so the other thing I want to bring into the conversation, because we did talk about that sort of bureaucracy that becomes very inefficient. And the other thing that's happened as well over the years is, with the health authorities, is centralization of decision making. And I think what happens with that is you lose the input of the community and the hospitals, and every community has different needs, and communities and hospitals tend to move faster. So let's say they budget for a certain innovation, they'll go for it, versus now what has to happen is you have to go through that level of bureaucracy to maybe try to bring in that innovation. And to be honest, it never happens, right? So this is something else that needs to be brought into the conversation is, has centralization worked? And has it made us less innovative? And we haven't evolved with the time because of decision making is from the top, and the top with all that level does not move quickly.
Sue.
Yeah, so this whole conversation around public versus private has gone on for decades and decades, and I think there's an opportunity now for us to hopefully embrace the reality that we're all in this together, whether you're public or private. We got to break the glass because we cannot afford this health system. And one thing that we see that the private system, and I come from Life Labs, right? So private provider of a public health service, and now in digital doing a lot of work with the private sector, is there's actually a very significant partnership that exists between the public and private sector when you scratch a little bit beneath the surface. And I'll just give one example on something that's been raised earlier, is the burnout of physicians and the amount of time, and we heard it from Nova Scotia, the amount of time that physicians spend on administrative work that creates this huge pressure. And there's, again, I keep coming back to technology, but there is a technology right now that's being deployed by Well Health, which is the largest organization of private frontline healthcare clinics in Canada that's being deployed to actually record using AI the conversation between patient and physician, and then can inform the physician in real time. Here's what was actually said. Here is what you might not have heard in terms of what might be going on in addition to what the patient has told you. And the physicians are getting 30% of their time back so that they can devote that to patient care, to patient interaction, rather than reading their notes, transcribing their notes, getting their administrative support people to interpret the notes, et cetera, et cetera. And that's being deployed right now live as we speak. And so there's again an opportunity here. And rather than pitting private and public sectors against each other in the health system, why don't we look at them as a partnership? And the private sector is prepared to try these things, to take them on, to experiment with them, to see if they work. And then and this is where Mary would have a ton of experience here. How you get adoption in the public system is I think the Rubik's Cube that I'm not sure that we've solved yet, but there's a huge opportunity here, even if the public system could do a trial or do one health authority or one hospital. And we've got some of those going on right now. I told you about the ultrasounds earlier that are getting used. How can we leverage that? Can we leverage that? Can we get it? It's a mind shift that we need in the public system, and it's right there available to us.
So one of the other issues, of course, is access to primary care. And if we take a look at what Jane Philpott is introducing in Ontario and what they've been now introduced in Alberta, we actually have a clip from Adriana Lagrange. Arav, can you please play that clip?
We believe the best way to get Albertans the health care they need and deserve is by creating 4 fully integrated provincial health agencies that will oversee the priority sectors of primary care, acute care, continuing care, and mental health and addiction. We have seen the stand-up of Recovery Alberta, which is the mental health and addiction agency, already. And today I'm pleased to announce another milestone, the stand-up of Primary Care Alberta. Primary Care Alberta will be the provincial health agency responsible for the oversight, coordination, and delivery of some primary health care services. What this means for Albertans is that they will finally have an agency that is dedicated to making sure their primary health care needs are met.
Valerie?
I think that's the root of success really is primary care across all countries around the world. It's where the first line of service is for patients, and especially in remote and rural communities. And Alberta is majority remote and rural, so as is British Columbia. So making sure that access to primary care is enhanced is so important. And with the new medical school that will be opened in BC soon, we're focusing on primary care. That will hopefully give a boost to creating more physicians in the specialty, but there's a dire need for primary care physicians and primary care nurses in BC as well.
Anna, that's of course.
Keeping the ones we have.
Yeah.
It's not just feeding. We're losing them out the back end more than we're bringing them in the front end. We've got to keep them, so keep them from burning out.
Anna, this has been your life.
Yeah,
Primary
and there's been, in terms of, the new school, unfortunately, before we actually see the first doctor from that school will be, 6 to 7 years from now. So that's a long time. There's been some movement in terms of, for example, sort of payment models, longitudinal family practice payment models, which, in a sense, sort of is good for primary care retention. The GPs like it, except the only thing is it has unintended consequences, is that you probably give better care to a patient and you're better remunerated overall, potentially, but you will see less patients. So it has had some unintended consequences. So, but I do agree. I think to actually look at primary care is not only how do we produce more doctors? How do we bring in more family doctors? But how do we retain them as well? So it's in the works. I think it is important, especially like you mentioned, in rural setting where often it's primary care that actually does the hospital work as well. So
yeah, Brian.
So again, I don't want to be tagged as being only thinking private here, but it is a fact that countries around the world have non-state controlled medical schools. So the United States, for instance, has 57 private, non-profit medical schools. And when you think about them, Harvard, Yale, Columbia, Stanford, these are not exactly second-rate medical schools. They're pretty good medical schools. And with a former premier, we were thinking of trying to get one of those private, non-profit medical schools built in British Columbia, actually on the Musqueam lands, with the support of the Musqueam Band. But unfortunately, that premier left and didn't happen. But I think there is a role for private. Even England has private medical schools. So I think there is a rule for private, not-for-profit, private-run, non-state controlled medical schools to fill the void. And then the other thing, of course, is there are many thousands of young Canadians going to medical schools in countries like Ireland and Australia, and over 50% of them don't come back. We're losing talent, and again, it gets back to the fact that we have to empower the patient by making patients something that hospitals and clinics want, by having the money flow with the patient, which is what happens in every other developed OECD. In every OECD country, the funding primarily follows the patient. It doesn't do that in Canada. That has to happen.
Sean, we have another question from a viewer.
We do. From Lone Clark. BC needs to look closely at medication not approved in BC, but approved in every other province in the country. For example, medication to treat MDS that dramatically reduces the need for patients to have very frequent blood transfusions.
Suzanne, what role can genomics play in helping us to maybe speed up those approval processes? Because we do have to be careful, but genomics and the research facilities that we have available here can accelerate that process.
Yeah, I mean, I think what we're talking about is a very complex issue, and I think I mentioned, genomic medicine, precision medicine is the future, and it does lead with the best research, but it also means we need to understand the environment in which that research is going to be deployed and the clinical interface. How are the caregivers, whether it's physicians, nurse practitioners, or the teams, going to interpret the information by understanding your individual DNA makeup, your uniqueness, and how you will metabolize drugs. And with that, in this current system, it's quite complex. We have approval levels from regulators, we have reimbursement programs, we have policies that are within government that decisions are made in different ways and ways of assessing the value and contributions of technologies. So it's a complex environment in which we need to understand the deployment of new technologies. And for Genome BC, that's why we're not just funding research anymore. We actually see part of our role is how do you understand the body of work that is needed when you're talking about using genomics to have personalized prescriptions for your condition. What does it mean to get it into the system? And it means we work with policymakers, those that are trying to understand ethical implications of decisions, when it may value a few people or when it will value a lot of people and it will be quite expensive. It means what are the considerations when you have a system that you need to have it centralized or decentralized? So there's lots of other work that needs to be done around accelerating the adoption, paving the way for the end users, the health authorities, normally to adopt these sort of things. And I was just going to comment, I think Anna was mentioning about efficiency versus innovation. And there are going to be examples where innovations and technology are going to supersede and just leapfrog ahead of any process we put in place. and use it. It'll just happen. I think the opportunity, though, is we do have evidence, and I just have to do one shout out to one of the projects we've just funded. Looking at organ transplant, and the survival rates or the rejection rates of organ transplants 20 years ago was 90%. The project we're funding today sees organ rejection at 0%. And it's because it can reduce the immune response of an individual. But that means we need the research, but if you're going to deploy that at scale, that's a pretty tough problem to do. That's where we need the health authorities and the hospitals to see the value of that data and decide how do you implement something like that across the board.
Well, that's a perfect opportunity for me to sort of, I guess, recognize the work that's being done through pharmacogenomics that you have worked with. But pharmacists also play a role. We have a clip from Mike Hudema of the BC Pharmacy Association. Arav, can you roll that clip,
pharmacists have long helped in the healthcare system by providing advice to patients as well as dispensing medications and for quite a long time providing vaccinations. But one thing that has changed for the better is beyond just being able to give the advice now for a lot of those same conditions we were giving advice for, we're now able to do the assessments properly as well as provide medication if warranted, or things like urinary tract infections or some minor skin ailments, things that otherwise we saw these same people in the past, the same conversations, but instead of having to direct them to their physician to further strain, we're able to take some of that off by helping them directly at pharmacy. That's the first thing that has changed. We've also now been able to extend prescriptions for longer than we used to be able to. There's a lot of people that are unattached to a family physician, or if not unattached, maybe aren't able to see them as quickly. We're now able to extend those prescriptions a bit longer to make sure that there's continuity of care so that they're not going without the medications and needing to go to ER or a walk-in for
a lot of energy towards saying, let us help so many other healthcare professionals who want to step up. One topic that has come up more than once tonight is that of block funding. Valerie, you've worked in other countries where they take on the issue of block funding and have said, no, it doesn't work. And we've tried it here. So, Mary, I want to come to you after Valerie. Talk about block funding and why other countries that are within the OECD group of countries have said, no, that's not the way that we're going to function.
That's a great question, and some of you have already raised this. So the block funding really means that a hospital will get a lump sum of money and then have to allocate it within their services, versus in other countries where it's activity-based. And so money follows the patient depending on really the activity the physician or the clinician provides to that patient, which means it's a lot more efficient to keep people healthy. And that's at the root of the access to primary care as well, is you care for a healthy population, therefore they cost a lot less. Therefore, you don't have to use more money to care for them when they're sick, versus the block funding really cares for the sick more so than the healthy. And there's no activity really reimbursed or paid for at the right price for the physicians that care for the healthy population. Mary, you've dealt with this a long time, so I'm sure you have a lot to add.
Well, it's definitely a very real problem. And so having managed the healthcare system in Vancouver, which has a tertiary hospitals, which has a lot of healthcare services, there's always that challenge in that you want to serve your own population well, but then people from the interior or from the north who don't have access to those, some of those services, or the wait times are longer because there aren't as many healthcare professionals up there. They want to come to Vancouver and they also want service. So how do you balance that out? Because you have block funding, which goes through a very complicated formula, which is fought fiercely every time it gets changed, as you can imagine, by the health authorities, taking into account the population, the age of the population, the income levels, the amount of teaching that each of the health authorities does, the rural nature. So it's very complicated, and it's never enough because it doesn't start with a pot that's big enough for everybody, for all healthcare. So it is a very real problem. That said, it only solves a piece of the issue. It's not the panacea for solving the healthcare problems, and actually it has opportunities to backfire a bit also, because one of the strongly agreed upon philosophies and initiatives or directions of healthcare these days is less care in the hospital, more care in the community. Many, many things through technology and better understanding of disease can be cared for in the community. Doesn't need to take up an expensive hospital bed. But if you're paying for a hospital visit at, say, $500 a day, and this can be cared for in the community for, say, $100 a day, you have a reverse incentive in that ideally we want it in the community, it's less expensive, more efficient, but the health authority will get more money if it's in the hospital. So you have to be careful that you've got a system that takes into account some of that.
Yeah, demonstrating. Valerie. Yep.
Maybe adding to that point, a lot of European countries have started to include caregivers in the health system delivery. And so there's incentives paid to family members or those that actually care for their loved ones at home to keep them home. And so they could be doing the ultrasound, they could be doing the wound care, send the exam, send the results to the hospital, to the physician in the tertiary care unit. And you actually grow the pie that way and include more of the caregivers in the process, which isn't really done here.
In fact, that's what we did in COVID, right? In COVID, and that's what gave rise to some of these technologies, is in COVID, the community health nurse network wasn't able to drive through the community and stop by and do all of this thing. And what we realized is family caregivers, not across the board necessarily, but in many circumstances, a family caregiver can actually provide an equivalent service to a healthcare professional if properly supported with guidance, with direction, with technology, and they have the time.
Yeah, so we can do it.
We can do it.
Yeah, Brian?
So when the money follows the patient, actually, it's better for the hospitals because there's an incentive to treat the patient and get them home quickly and bring in a new patient who needs a hip replacement or ankle surgery or a procedure done, because the revenue is increased. We talk about $500 a day for a hospital. A patient who's festering in a hospital and staying there for a long time is not bringing in very much revenue once the procedure is done. The money following the patient generally applies to getting procedures done in the hospital, and that's why there's an incentive to treat more patients more efficiently, more effectively, and have them go home quickly with a good recovery.
So we're going to run out of time, but there's a great question that I think is a closing question to all of you that has come in from a viewer. Sean, can you please pose that question? I'm going to ask each of you for an answer.
Thanks, Stuart. The issue facing our healthcare system seem overwhelming. If you were premier for one day, what one thing would you change to have the greatest impact and start us in a better direction?
Brian?
Well, I would do two things. So I would bring in and start and end to block funding, start the money following the patient, and secondly, a healthcare guarantee, so that if you're waiting beyond the time that the data shows is harmful for a procedure, then the state will cover you to get that done elsewhere.
You'd follow the guidelines that now exist in Quebec following the Chihuly decision. Yeah. Suzanne?
I would go all in on changing the mindset of those vehicles that are adopting innovation, and to be bold and ensure that there is an interface that is ready to be agile and able to adopt new technologies. I know that sounds simple, but I know it's very complicated.
But we have the talent pool here and the interest. Sue?
Yeah, so thank you for the question. I'd go to what gets measured gets done, and would start measuring based on the health outcomes rather than the number of people that come in, but what are the outcomes that are delivered. And you get rewarded based on shorter stays in the hospital, healthier outcomes, lack of readmission, and there would be incentives to create a healthcare system rather than a sick care system. So go to what gets measured gets done, and measure outcomes rather than inputs.
Anna, you might be closer to that opportunity to make those kinds of differences, but if you were Premier for a day, what would your number one issue be?
I changed my mandate to a 10-year term. So we meant, no, I'm just kidding, because this will, I agree with some of what's already been said. I think we need to look at different models, activity-based funding, but also with a measure of quality to it, because with pumping in patients, you can also pump them out, and the quality measures would maybe go down. So you want to make sure you attach it to a measure of quality. And Brian also mentioned guarantee of care. And what guarantee of care means is, if you're, if there's a parameter of wait times that you've surpassed, you actually will get care elsewhere. So if it's in the same province or another province or another country, we will pay for it. And again, I'm repeating the same things, but I agree with what was said. Was if you can't measure it, you can't make decisions. And by measuring, I also would actually do what I would call a forensic audit of the entire system, to see what is actually, and what is actually working and what is not working, and streamline the whole system and funnel money towards the front end, which I think is very, very much needed.
Valerie?
I think to figure out what to measure would take bringing in partnerships together. And so if I had one day, I would actually get the key leaders in the room together and close the door and make sure that everything was said in confidence, but that they had the freedom to invent and recreate and redesign something different. So they could have an innovative system that was built on public-private partnership, because I think that's what we need to move forward as well. And it would have key measures and decisions made in the room that day that would then follow through in the next term.
And Mary, you've been in those rooms.
A day is only 24 hours. And we've been critical of governments changing every 3-4 years and not able to get the job done. So I'm not sure that I would even accept the job. I probably would have to resign as Premier. But to me, it would all be about leadership. So how can you get the leadership in place in one day that is going to have the courage, have the ambition, have the sustainability, have the willingness to lose the vote if that is the case. But if you're smart, you can probably figure out what does the public want and see and is visible that will give you kudos in the voting box, as well as thinking carefully about what system in a holistic manner, what that redesign needs to look like, building on some fantastic ideas that we all heard today and that I learned a lot from. But one day,
Yeah. Well, one can hope that those who have that ability are listening. We did put out a call to the new Minister of Health to join us, but unfortunately they declined that opportunity. But we hope that people are listening and that many of these excellent ideas do get shared. I want to thank all of our panelists for your contributions tonight. Thank you. And for the other contributions of people that we recorded earlier. Thank you very much. And before we go, I want to give one more shout out to Helicopters Without Borders. If there's anything that you have heard tonight and that you can see the extraordinary work that they're doing in providing services to really rural and remote communities, if you can support them, that would be great, because it's all part of the same healthcare equation. We'll be back in January. Until then, we wish everybody a wonderful holiday season, and we'll see you again on January the 28th. Thank you.